Hello everybody, today we are going to talk on the biomechanics of the wrist. My name is Dr. Srinivasan Rajappa. I am a professor of orthopedics. I am an orthopedic surgeon by training. I work in the Sri Ramachandra Institute for Higher Education and Research at Chennai. I also head the Department of Hand Surgery. The biomechanics of the wrist is important from 2 points of view. One is, if we do not understand the biomechanics of the wrist, it is going to be very difficult for us to understand the problems of the wrist and give solutions to those problems. Hence, for anybody who is going to be dealing with the problems of the wrist, it is important to understand how the normal wrist works. Secondly, anybody who is listening to this could be a person who is preparing for an MS Orth or a D Orth exam, and biomechanics of the wrist can be a short note or a long note in an essay. So that is the importance of wrist biomechanics. Now let's start with the bones of the wrist. As we all know, the wrist has got the radius and the ulna, which is component of the forearm. It has got the scaphoid, lunate and the triquetrum, which is the proximal carpal row. The hamate, capitate, trapezoid and the trapezium forming the distal carpal row. And then of course we have the articulations between distal carpal row and the base of the metacarpals. Now the joint between the radius and the ulna and the proximal carpal row is called the radiocarpal and the ulnocarpal joint. Of note is the fact that the pisiform does not articulate with either the radius or the ulna, and it articulates on the palmar side with the trapezium. As we go distally, we are coming to the midcarpal joint, which is the articulation between the proximal and the distal carpal row. There is a considerable amount of movement of the wrist which happens in the midcarpal joint, especially the dart throwing motion. We will talk a bit more about it as we go. As we go distally, the carpometacarpal joints are formed between the base of the metacarpals and the distal carpal row. Of note is the fact that as we move from the index finger to the little finger, the rigidity and the stability of the carpometacarpal joint progressively decreases as we go towards the ulnar side. Or in other words, the carpometacarpal joint of the little finger is much more mobile than the carpometacarpal joint of the index finger. This is the reason why humans have this quality of opposability of the little finger, which is very exclusive to the human race and not opposability of the thumb as it is usually thought. We look at the alignment of the carpal bones. Now the picture on the left side is a wrist radiograph, the lateral view. If you look at it, you have the radius, you have the lunate, you have the capitate and the third metacarpal. If you draw a straight line along these, they all intersect in the middle. And that is the normal alignment of the carpus. You have the radius, the lunate, the capitate and the third metacarpal. They are all in the same line. Also of importance is the fact that the scaphoid, which is here, is not looking there, but it is looking a bit palmarwards. Or in other words, the scaphoid is sitting at a 45-degree angle to the longitudinal axis of the wrist. Now, why is this important? If you have to image the scaphoid, you either have to get the scaphoid up by ulnarly deviating the wrist, or you have to direct the image at perpendicular to this angle so that you get a complete view of the scaphoid instead of directing the angle in this way, where you're going to get only an incomplete view of the scaphoid. The picture on the left side illustrates the whole thing better. We go through it one more time. You have the radius, you have the lunate, you have the capitate and the third metacarpal. In every lateral view of the wrist from now on, you should make it a point to draw this line and see if all of them are in the same line. Also, remind yourself that the scaphoid is looking palmarwards and it is at an angle of about 45 degrees compared to the axis of the wrist. It is also important to note here that the concavity of the lunate is looking straight. The lunate is not looking up nor down. If either of these things happen, then that is pathological. We will talk about it a bit more as we go. Now this is a X-ray where the orientation of the concavity of the lunate is pathological. Now as I said in the previous slide, the lunate is supposed to look straight, but in this picture you can see that the concavity of the lunate is looking up. So this is a DC. Now if you come to the same picture on this side, you have the concavity of the lunate, which instead of looking straight there is looking more towards the palmar side, or in other words, this is called a VC. The other applied anatomy of drawing this line but from the third metacarpal across the capitate, across the lunate to the distal radius, is that many times in some injuries of the wrist, you can have this line which is sort of broken. So if you draw the same line in this picture, you have the third metacarpal, you have the capitate, and then there's nothing there. So this line is sort of broken there, and here is the lunate lying here. This is the classic picture of a perilunate dislocation, and it is important to remember that many of the perilunate dislocations are missed acutely. So again, I want to emphasize the fact that whenever you see a wrist lateral, please make sure that you draw the line, and also make sure that the scaphoid is neither too flexed nor too extended in a lateral view. Now coming to the ligaments of the wrist, they are like many other joints. They are the extrinsic ligaments and the intrinsic ligaments. What are the extrinsic ligaments? The extrinsic ligaments originate either from the radius or the ulna, and they get attached to different carpal rows. Now as you can see in the example here, this is the radioscaphocapitate ligament, and it originates from the radius and gets inserted into the capitate going across the scaphoid. You have the radiolunate ligaments, and then you have the ulnocarpal ligaments. We will see a better description of this in the subsequent slides. If you look at the intrinsic ligaments of the wrist, the intrinsic ligaments originate in the carpal bones and get inserted to another carpal bone. It need not necessarily be the adjacent carpal bone, as is shown here. It can be a carpal bone which is a bit farther apart. So here you can see the scaphoid, the lunate. This is the scapholunate interosseous ligament. You have the lunate, you have the triquetrum, and you have the lunotriquetral interosseous ligament. This is the dorsal intercarpal ligament.